Dear colleagues, good afternoon from Athens, Greece. I would like to thank Professor Belginer for her kind invitation. It's always my pleasure to take part in your congress. I would like to talk about bone and muscle impairment in spinal cord injury. As you are aware, the bone and muscle have a common developmental origin from mesenchymal cells. The pleiotropic genes have a positive effect on muscle and bone, and adversely environment has negative effect on both of them. Endocrine hormones like testosterone, estrogen, the physical activity through the mechanostat, vitamin D, all have a positive effect on muscle and bone. And there are some muscle-derived peptides with possible effects on bone, some with positive and some with negative effects. But we know now that bone is also talking to the muscle through the osteokines. Bone and muscle composition deteriorates during the first months after injury, and this begins immediately. This reduction is reported in the first years of 4% per month in regions rich in cancellous bone and 2% per month on sites containing mainly cortical bone. Meanwhile, total body lean tissue mass decreases as much as 9.5% by 6 months, whereas leg lean tissue mass decreases more than 15% by 1 year post-injury. And SCI-related bone impairment, muscle impairment below the level of injury is much greater compared with other conditions, for example, age, immobilization, lack of graft environment, etc. In acute and chronic phase, bone impairment has a multifactorial pathophysiology. It's coming from denervation, from unloading, from hormonal changes, from the negative calcium balance. All this leads to bone resorption. Before proceeding, I would like to remind you the Frost mechanostat theory of bone muscle unit. We know that if sufficient force is applied to bone, a certain threshold strain in the bone is reached and bone is synthesized. This is the right area of this curve. If muscle force is below a certain point, if for instance muscle are immobilized or paralyzed, bone tissue is lost. This is the area here, the remodeling area, leading to bone resorption, and this is the case in spinal cord injury. However, is this theory valid in spinal cord injury? The largest forces under physiological conditions arise from muscle contractions, and after SCI, sensory and motor function are disrupted due to damage of the neural tissue within the spinal canal. In most cases, this does not imply complete loss of muscle contractions, as spasms and pathological spinal reflexes do frequently occur in most SCI patients. It could be argued that the reduction in muscle strength would be not the cause, but rather a parallel to the reduction in bone strength, as there are many evidence that there is an involvement of central nervous system in bone metabolism. Such nervous influence could be better understood for sympathetic nervous system, which is thought to hamper bone formation and stimulate bone resorption. However, sympathetic nerve activity is decreased after SCI. Accordingly, one should expect increases in bone mass and strength via this pathway, which is not the case. So this theory is valid in SCI, in space, and everywhere. What's new now in the pathogenesis? We have now another player, sclerostin, and many good publications coming from the US, from Leslie Morse, about the conceptual model of sclerostin-mediated bone loss following SCI. This mechanical unloading in acute SCI subjects, this causing increased sclerostin levels, here with black upward arrows, in paralyzed compared to able-bodied, and this increase is associated with increased bone formation during the acute phase, reduced bone formation during the acute phase of SCI. The ability to walk, the mechanical loading in, for example, the incomplete paralysis, modulates the response of bone to paralysis by causing a smaller increase in sclerostin levels, thereby protecting against bone loss, lesser decreases in BMD. In the chronic phase, bone wasting results in lower sclerostin levels than those observed in the able body, but this effect is due to the reduction of sclerostin-producing osteocytes in the sporotic bone. In the chronic phase, similar to the acute phase, the ability to walk partially protects against bone loss, and there is a putative therapeutic window to target sclerostin here with dotted bracket, which is in the area below, in the time area below 6 months. So the reduction level of sclerostin levels and promotion may be possible during the first 6 months only. On the contrary, treatment with an anti-sclerostin antibody in chronic SCI would be ineffective. However, these findings need to be confirmed in more studies. Coming now to the duration of paralysis at the new steady state. Bone is lost but is stabilized to a new steady state many years after the paralysis. This is the case for the trabecular bone, which is lost many years, more than 7 years after the paralysis, but not for cortical bone, which reaches its steady state at 2 years after the injury, and so does the muscle. Muscle atrophy reaches very early the steady state, and it's likely to maintain by reflexing activity the muscle spasms. And we know that the long-term maintenance of functional structural muscle properties suggests that treatment can begin at any time after the injury in these patients, possibly with the same or similar efficacy. Even during the late stage of upper motor neuron injury, there are no deadlines, at least up to 20 years per injury, to successfully launch a rehabilitation program. Coming now to biochemical markers. The use of markers revealed that bone resorption increases continuously from the first week after injury and reaches the peak between 10 and 16 weeks, with values up to 10 times normal. Furthermore, after the year, indices of bone resorption remain elevated. At the same time, indices of bone formation suggest a minimal increase. Hypercalciuria seen in 10 days after injury and reaches its peak at 1.6 months. It's 2 to 4 times the calciuria observed in log bedridden subjects, and remains in various degrees after the next 12 months. And excessive secretion of calcium in urine leads to hypercalcemia. Hypercalcemia develops 4 to 8 weeks and can be started earlier by 2 weeks, and especially in renal insufficiency is very dangerous. Hypercalcemia occurring immediately after injury is responsible for low levels of PTH. The decreased PTH is associated with increased concentrations of serum phosphorus and reduced synthesis of 1.25 dihydroxy vitamin D. It's a little bit complicated, but it's the endocrinology of this disability here. You can see here now alkaline phosphatase is in the upper limit, almost in the upper limit, is increasing in the upper limit, is an index of bone formation. On the other side, calcium is increased very much, it's above the upper limit of normal, and parathormone is going down here. And these are also indices of bone resorption which remain elevated many weeks after the injury. To understand what the specialists in spinal cord injury believe or know about this assessment and management, we conducted with some colleagues a survey, a pulse survey, and received some variable answers. For example, if they measure bone loss in SCI, which test do they prefer? They prefer to measure calcium, parathormone, vitamin D, DEXA of spine, DEXA of hip, etc. The therapeutic approach to prefer for during the acute and subacute phase to stop bone loss. They prefer mobilization, they prefer vitamin D, they prefer calcium, and a small percent of less of 35% prefers the use of bisphosphonates and much less prefer the denosumab. We will see in the following the presentation what the recommendation now are saying. We have many good recommendations now published from Crave and colleagues in SCI Professional about bone health and following spinal cord injury. She repeated her definition about sublesion osteoporosis in men above 60 years or postmenopausal women. Hyopic region T-score below -0.5, 2.5. Men below 59 years or premenopausal woman, he or knee region Z-score below minus 0.2 with more than 3 risk factors for fracture. And men or women aged 16 to 90, prior fragility, fracture, and identifiable etiology of osteoporosis other than SCI. The risk factors for lower extremity fragility fracture after SCI are pretty different than those in osteoporosis for postmenopausal women, for example. Here we have the age at injury below 16 years, alcohol intake more than 5 servings per day, body mass index below 19, duration of SCI more than 10 years, to be a woman with a complete paralysis, paraplegic, family history of fracture in men, the use of anticonvulsant, spasticity medication, opioid analgesia, prior fragility fracture, SSRI, the use of SSRI, PPIs, and knee region below the fracture threshold, because now we have values for fracture thresholds, which are the values below which fragility fractures begin to occur. And we know we have these values for DEXA devices and for volumetric devices in the knee region, because our area of interest is the knee region. Paraplegic fractures are happening in this region and not at the hip and not at the spine. So we need to know the volumetric BMD or the aerial BMD at the knee. Coming to the definition again, back to the terminology. A few years ago, American surgeons, orthopedic surgeons, call it bone impairment. And I believe this terminology is quite good because it describes well this, which is happening on bone. This is the bone of a paraplegic man. This is the area should be red from compact bone. Now it's substituted with fat. This is now the cortical bone. It's very thin, as you can see. Cortical bone. It's not the normal osteoporosis we are dealing with in postmenopausal women. It's something different. And in rehabilitation, according to the International Classification of Functional Disability in Health, the term impairment refers to a problem of a structure or organ of the body. In this case, is the bone structure or the muscle structure. And this term, we follow this terminology in this S1 guideline on bone impairment, spinal cord injury, published a few years before with some colleagues from bone field and from rehabilitation field. And I would like to thank Dr. Anni Rapidi, my colleague, for her help to finalize this project, and also Professor Belginer Han, who also participated in the project, also Martin Mamura, who is co-chairing the session with me. This project didn't come from nowhere. It synthesized recommendations from many societies, from German-speaking Society of Paraplegia, from Hellenic Osteoporosis Foundation, from Hellenic Section of Spinal Cord Injury, from SAI, etc. Coming now to the loss of muscle and sarcopenia, we know that recently there was an update in the criteria for the diagnosis of sarcopenia. Now low muscle mass and low muscle strength are important criteria for established sarcopenia, but for severe sarcopenia, we need to add the criterion of low physical performance. Now, let's see what's happening here. It's not sarcopenia of age-related persons. It's not a primary sarcopenia. We are discussing about secondary form, which is combining elements from activity-related secondary sarcopenia, from disease-related sarcopenia, from nutrition-related sarcopenia. And this is pretty complicated because here we do not have this pronounced innervation of type 2 fibers and the recruitment of type 1 fibers into the survival motor units in older subjects, like it is in older subjects. We have other pathophysiological processes. We have the loss of motor neurons here. We have malabsorption, who leads in protein deficits and muscle catabolism, and the use of muscles, use of physical inactivity, followed by muscle degeneration and hormonal disturbances of the thyroid, hypercortisolism, and insulin resistance. And we know that motor neuron death occurs irrespective of the level or cause of human spinal cord injury, and denervation must contribute to the severe atrophy that is measured in muscles. And from Skelsey, many years before, I republished this table because he told us that this use leads to muscle fiber atrophy, capillary decrease, and myopathic changes, which lead to fast fiber 2 predominance in this population, and the same does spasticity with fiber type transformation, which is the opposite of this, which is happening in age-related sarcopenia. So we are dealing here with a different entity. And moreover, there is the limited availability of many nutritional elements because there are many complex metabolic changes in spinal cord injury, but also in other neuro disabilities. And we published it a few years before. It's very complicated now. I don't want to stay in the slide. I would like to proceed in order to save some time. The dominant risk factor for bone loss is the duration of injury and the extent to the spinal cord. And individuals with a complete motor lesion have lower bone mineral density values in the affected limb than those with motor incomplete paralysis, of course, because in incomplete paralysis, some muscle activity remains. And the damage to the lower motor neuron is considered a further clinical risk factor. Bone loss is more pronounced in individuals with this flaccid spinal cord injury than in individuals with intact lower motor neuron. Coming now to the diagnosis, the measurements, blood, urine measurements, test, and DEXA. In our recommendation, in our publication, S1 guidelines, we proposed in this table all these biochemical parameters in serum and urine we need to measure in this population, as you can see, in order to exclude other secondary causes for osteoporosis, like, for example, calcium, phosphorus, creatinine, phosphatase, etc. And recently, the International Society of Clinical Densitometry published an official position, Leslie Morse and Craven again, and answered 4 questions related to the clinical usefulness of bone density assessment in people with SCI. The question 1 was, what are the indications for initial DEXA in individuals with SCI? And they answered that finally that all adults with spinal cord injury should have a DEXA scan as soon as they are medically stable. That's normal, we understand. And if this densitometry can be used to diagnose osteoporosis, assess fracture risk, or monitor response to therapy. And they answered, the position is that in adults with SCI, total hip, distal femur, and proximal tibia bone density should be used to diagnose osteoporosis and predict lower extremity fracture risk and monitor response to therapy where normative data are available. To comment on that, it's not so easy with our software devices to measure DEXA at the distal femur and proximal tibia. We do not have many data. And how should DEXA be used to monitor osteoporosis therapy? So DEXA should be serial DEXA assessment should be used to include evaluation of these areas, hip, distal femur, and tibia, following a minimum of 12 months of therapy at 1 to 2 year intervals. However, in our recommendation, we propose the rule of Ulm. That means that we need to measure DEXA every year during the first 3 years after paralysis, and every 2 years after that, and then 1, 2, 3 years, first years, and then 5th year, 7th year, 9th year, and then after 3 years, then 12th year, etc. This is the rule of Ulm, 3 times 3. We believe it would be a better way to measure this loss of bone. However, they propose that whole body DEXA scan should not be used for monitoring treatment. This is very important because we found some answers in our survey that some colleagues measured with a whole body scan the area of the knee, which is totally wrong. Are the DEXA-based criteria that are absolute or relative contraindication to exercise-based therapy? There is no establishment threshold BMD value below which weight-bearing activities are absolutely contraindicated. However, we need to assess BMD and clinical risk factor before our subjects start the rehabilitation program or engage with the weight-bearing activities. This is important. And how now we can assess the muscle mass with the same device DEXA but with another software, and we take this kind of pictures. This is the normal one, able body. This is the paraplegic one, and the similar values. In this, with this device. And from this measurement, we get an index, the skeletal muscle mass index, which derives from appendicular skeletal mass divided by head square in kilogram per meter square. We know the normal values in men below 7.26 is sarcopenia for men, and for women below 5.45. But these values are valid for elderly subjects, not for paraplegics. Now, coming for measurement of muscle strength and performance for sarcopenia in SCI, are there any strength and physical performance tests reliable for this population? We cannot do knee extension, of course, in paraplegics, or the 4 meters walk test or the 6-minute walking test. These tests are pretty difficult or unavailable in this population. However, are there any other solutions? We can use in research field only PQCT devices who measure muscle cross-sectional area, and muscle cross-sectional area has been proposed as a surrogate for muscle effectiveness or loading of force in this population, and can be obtained with a single slice in 66% of the tibia, and in subjects can be measured more precisely. It does not depend on motor function of the lower limbs, which is impaired. And we measured that in a study and found that these values, of course, were lower in the paraplegics group here, A and B, compared to controls. And we use it to publish about sarcopenia definitions in how to apply the current sarcopenia criteria in spinal cord injury, and found that paraplegics had the SMI skeletal muscle index below 5.8 and 5.3, depending the method used. That is an index below the index of women, of course. And coming now to the prevention and treatment of bone and muscle loss, we need, of course, to counseling is very important, to give the lifestyle modification, to explain, of course, the anticipated decline in hip and knee region, to how to transfer, for example, in and out of his wheelchair will be important, to encourage him to pursue an alternative recreational activities, to restrict coffee intake, to discuss smoking cessation strategies with the subject, and about the prophylaxis. Is possible? I believe yes, because I was taking this debate against Anderson and Park, coordinated by Leslie Morse, and I believe that in acute SCI, calcium dietary intake is very beneficial, because the suppression of parathermal results in reduced absorption of calcium in gut. However, other colleagues highlight the risk of calcium nephrolithiasis after acute SCI due to high bone turnover, and this may misguide people with SCI to avoid diarrhea products or calcium intake. But hypercalciuria after abrupt immobilization is due to unregulated bone resorption and not appreciably influenced by dietary intake. So we believe in our recommendation that we need to give 1,000 milligram daily as recommended dose from the conventional diet. And before starting therapy, we need to always check vitamin D, because supplementation with vitamin D is always necessary. If vitamin D is not normal, below normal, calcium is inadequately absorbed. And if we provide an anti-resorptive agent like bisphosphonate or denosumab, we strongly suppress more bone resorption, and this leads to severe hypocalcemia. These are things we need to know when we are giving such drugs. And the role of vitamin D is very important. We need to provide them 800 to 1,000 international units per day. We need a level of 30 nanogram per ml. This is the optimal for this population. Coming now to pharmacotherapy, we have new data published in a review from William Bowman, very known in the field. He criticizes some previous publication about the early treatment with zoledronic acid, which prevent bone loss at the hip. Okay, it prevents bone loss at the hip. It is shown here, all area on the neck, on the trochanter area, total hip, as you can see here with red. However, they performed a study showing that this drug failed to prevent bone loss at the knee, which is our area of interest. Here is, it was good for the hip region, but not good for the knee region, which is our area for interest to prevent these paraplegic fractures. What denosumab, coming now to denosumab, which increases sublesional bone mass in osteoporotic individuals, as you can see here in the total hip, in the femoral neck and the lumbar spine, of course, but also decreases all biochemical indices, either formation or resorption. Administration of denosumab preserves bone mineral density in persons with subacute spinal cord injury, so denosumab may be a good solution. And coming now to remosozumab, the new monoclonal anti-sclerostin antibody in rodents here. In this study was begun 12 weeks after complete spinal cord transection, and the treatment continued for 8 weeks, and BMD was restored, as you can see here with these gray bars, excuse me, these gray bars was restored BMD, and the structure was better in the group of rodents who received this anti-sclerostin antibody. So romosozumab may be a good solution in the future for our subjects. At what BMD value, T-score or Z-score, should we provide the therapy? We should provide therapy in all wheelchair-bound subjects. All are endangered to fractures, and we do not need to wait for fractures to occur. And for patients with ASD who can walk, references make to the WHO guidelines, and we need to pay attention to those with the ASE, then the so-called normal, who may be not sensitive, because we know that ASIA motor sensory scoring may be not sensitive to subtle weakness, presence of spasticity, pain, certain form from dysesthesia. So coming now to non-pharmacological approaches, we have standing, walking with braces, all this functional electrostimulation, cycling, vibration, pulse electromagnetic fields, or have some studies. However, only this countermeasure, the functional electrostimulation, is this treatment needs to, it has very good results, but and cycling, fast cycling also, but needs to be ongoing, or the benefits will be lost. Okay, the vibration plate through the action of from the muscles to the bones. However, this is also in research. And do not forget to give them nutritional supplements, proteins mostly for muscle loss. Of course, you need to measure their kidney function, if there is a possibility of renal insufficiency, we need to be very careful. And of course, exercise prescription is another part. It's a very difficult issue. There are problems which should be addressed. The reduction in cardiovascular fitness and work capacity, by the loss of sympathetic control, the functional muscle mass is reduced. Other issues of concern is the inability to respond to the training program because of the Better syndrome, because the heart, the lung, the muscles above the lesions are not conditioned to exercise. And for the prescription, the following parameters are very fundamental: the frequency of movements, the intensity and duration, and the exercise should be performed at 3 sets at an intensity rather 40% of a single maximal repetition. And with this, I would like to thank you for your patience and your attention.